Hi everyone, thank you for joining us for this tutorial. So today's tutorial is on rheumatological conditions given to us by Devika. So just a few rules. If you're watching via Zoom, any questions or comments that are covered in the moment, if you just want to pop into the chat, and any questions I can wait to the end if you just want to pop into the Q&A. If you're watching the Facebook Live, just comment your questions and your comments and I'll pass them on to Tutor. And I just want to say thank you so much for just coming to all the tutorials. This is the last one in our Back to Med School series. So it's been good doing these tutorials and it's been good that you guys have joined and I hope you've learned a lot. That's all from me now and I'll just pass over to Devika. Thank you.
Hi guys, thank you for joining in. So today's session is about rheumatological conditions. That's just a disclaimer from becoming a doctor. The learning objectives for today is to gain knowledge about various rheumatological conditions. So understand the management of these conditions and try and identify key features of such conditions, which will make it easier for you to diagnose and then treat them subsequently. So the structure of today is we'll be going through 8 cases and then there'll be some questions towards the end. We'll see how we go with time and I'll try to take breaks in the middle to answer your questions. So let's start with the first case. Here you've got Mrs. Jones, who is a 68-year-old lady. She's presented to the general practice with intermittent aching pain in her right knee for the past 6 months. Her BMI is 29. She's referred for X-ray of her right knee, and here you can see the X-ray. So given her X-ray, what is the most likely diagnosis? I'll just begin the poll for you guys. And that should be live. So I'll give you guys about 10 more seconds to answer them. Okay. So I'm hoping you guys can see the results now. So half of you said osteoarthritis, which is the correct answer. We've got a few votes for rheumatoid, a vote for osteoporosis, and one for normal X-ray. So it's good we've got a range of answers. We can work through them and see why it's osteoarthritis. Right. So in this question, you can see that she's a female. So for being a female is a risk factor for osteoarthritis, and so is being overweight. She's got intermittent aching pain. Well, yeah, that's not exclusive to osteoarthritis, but points towards it. And the thing that really gives it away is the X-ray. So in the X-ray, you can see these, I've highlighted in these circles, these tiny little, sort of anomalies. And you can see, which are basically osteophytes. And you can see that there's a loss of joint space. The joint space is slightly reduced. And the arrow is kind of pointing to a little bit of sclerosis. So sclerosis is basically this white line, and if it keeps getting whiter, if it's more sclerosed. So for osteoarthritis, the classic X-ray signs you see is loss. That's loss of joint space, loss of joint space, osteophytes, sclerosis, and subchondral cysts. In terms of, no one answered gout. It's unlikely to be gout, especially because of the X-ray findings. Rheumatoid arthritis, yeah, it is a possibility, but rheumatoid's more likely to affect the smaller joints of your hands and feet. It can still affect the knee, so it's a good differential to have in your mind. Osteoporosis is unlikely to be symptomatic. It's usually asymptomatic, and then a patient will present with either a fragility fracture or it might be an incidental finding. A normal X-ray, well, here you can clearly see that there are X-ray changes. So we go with osteoarthritis as the answer. So in terms of osteoarthritis, it's basically a wear and tear in your joints. And this happens because there's an imbalance between the cartilage being worn down and the chondrocytes repairing it. Risk factors is obesity, age, occupation, trauma, female, and if there's a family history. In terms of clinical features, it's joint pain. You can possibly have some stiffness that's worse with activity. There can be some deformity. You can have reduced function of the joint. And the commonly affected joints are your hips, your knees, sacroiliac joints, DIPs, and MCP joints at the base of the thumb. In terms of the hand, there are 4 signs that you sort of look out for. And 2 of these common ones are Herpeton's nodes and Bouchard's nodes. So the way I remember it is HD, that's Herpeton's in the distal area, and Bouchard's in the proximal, so BP. The other things you can look out for in the hand is the reduced range of motion if they have a weak grip, or squaring of the CMC joint at the base of the thumb. In terms of investigation, it's a clinical assessment. So NICE guidance. So NICE actually suggests that you can make a diagnosis of osteoarthritis without any investigations if your patient is over 45, they have typical pain related to osteoarthritis, and that they have no morning stiffness, or if they do have morning stiffness, it's less than 30 minutes. So yeah, and then you can of course do an x-ray if you have a clinical suspicion of it, which can show the signs we saw in the previous question. An important point to note is that your x-ray changes don't always correlate to the symptoms. So you might see quite a few times that a patient who has severe x-ray changes of osteoarthritis may not actually be experiencing a lot of pain, and vice versa. So in terms of management, the way I like to remember it is we first start with the patient. So patient education, lifestyle advice, so reduction in weight if they're overweight, obese, physiotherapy, so you want to strengthen the muscles, and over-the-counter analgesia. If they've tried all this and that hasn't worked, then both, so that's when the patient and the doctor are sort of meeting midway. So you might think about stronger analgesia, and then you can think about intraarticular steroid injections. And then, of course, if that hasn't worked, then it comes to the doctors, it comes to the medical field in terms of surgery. So either total or a partial replacement of the joint, and whether it's total or partial would sort of depend on the patient, their comorbidities, their preferences. And that is the endpoint in terms of treating osteoarthritis is surgery. So a question I like to ask you guys is, how would you distinguish pain from a mechanical issue, such as osteoarthritis, from an inflammatory arthritis? There's no poll, but if you guys just open your chat box and try typing a few answers, and then we can see how you get along. Yeah, okay, so we're getting effusion, no, but yeah, pain that gets better throughout the day. It's inflammatory. So yeah, we're sort of on the right lines there. Inflammatory markers can actually be raised in, yeah, I can see it. It can be raised, not in osteoarthritis in particular, but they could have other comorbidities that might be raising it. So that won't be a distinguishing factor. Morning stiffness, yeah. Age won't necessarily play a role because while rheumatoid might come in a bit younger patients, you can still have inflammatory and mechanical issues in older and younger patients. So we did sort of get to the bottom of it. It's pain. So if you have a mechanical problem such as osteoarthritis, your pain is worse with activity but improves with rest. But if you have an inflammatory arthritis, such as rheumatoid, your pain will improve with activity and gets worse with rest. So patients will often say, I have really bad pain and stiffness in the morning, but then throughout the day, it just keeps improving as I do activities. So at that point, your mind is thinking something inflammatory is going on, possibly an inflammatory arthritis. Right, moving on to the next case. So here you've got Henry Jones, who's a 52-year-old male. He's presented with bilateral shoulder pain and stiffness for the last few weeks. His stiffness lasts in the morning for approximately an hour. He has a past medical history of type 2 diabetes mellitus and giant cell arthritis. Given the above information, what is the most likely diagnosis? And I have launched the poll, so you guys feel free to vote. So give you guys about a few more seconds to put in your votes. Okay, so we've got the majority of votes is for polymyalgia rheumatica, which is good because that is the correct answer. And we've got a few votes for rheumatoid arthritis as well. But let's just work through all the answers to see what is polymyalgia rheumatica. So in this patient, so they're in sort of well, not very elderly, but yeah, an old patient. They've got bilateral shoulder pain and stiffness, and they have a history of giant cell arthritis. So polymyalgia rheumatica has a strong link with giant cell arthritis. So that should probably just pop up in your head. The fact that they've got shoulder pain and stiffness, and it's bilateral again points to polymyalgia rheumatica. That's quite characteristic of it. Rheumatoid arthritis, yes, again, an important differential to keep in your mind, especially because there's stiffness in the morning that lasts for an hour. But it's unlikely to affect the bigger joints. It's more likely to start with the smaller joints. But yeah, it can affect because rheumatoid is a symmetrical polyarthritis. So maybe if there were more joints involved, you would think about rheumatoid. None of you answered ankylosing spondylitis, and that's good because that you would more think of someone with AS if they're presenting with back pain or back issues. Reactive arthritis, there's no recent infective trigger, so you wouldn't think about that. And the last option usually affects the exocrine glands, and there's nothing in the history to point towards that. So polymyalgia rheumatica is an inflammatory condition. It's more common in Caucasians, women, and if you're aged over 50 years. There's a strong association with giant cell arthritis. And the core features, which I will discuss, should be present for at least 2 weeks. So these are bilateral shoulder pain, possibly radiating down to the elbow, bilateral pelvic girdle pain, worse on movement, and morning stiffness that lasts at least 45 minutes. There can be other features, and these can be pitting edema, systemic symptoms, weight loss, loss of appetite, carpal tunnel syndrome. The other features are quite vague. And in terms of investigation, I like to think of it as a diagnosis of exclusion, sort of like IBS and GI. So you diagnose it with your clinical assessment, and then you give steroid and see how they respond to it. But of course, before you do that, you also want to rule out any other condition. So you can do some baseline blood tests, antibodies, urine analysis. It depends on how the patient presents. It depends on your clinical judgment. So you want to rule out anything more severe, and then you want to diagnose them and start them on steroids. So steroids is the management. You start with 15 milligrams of prednisolone. You want to assess them at 1 week, and then at 3 and 4 weeks. When you assess them on the first week, and if they have a good response to steroids, you continue them, and then it's likely that they've got polymyalgia rheumatica, and that's your diagnosis. But if at the end of 1 week they say, "Oh, doctor, I'm feeling the same," then you need to stop the steroids and investigate for other causes, because it's unlikely to be polymyalgia at that point. And yeah, after 3 to 4 weeks, you want to consider reducing the regimen for steroids. In terms of the reduction regimen, it can take months for them to reduce and sort of wean them off steroids. They can have flares up in the middle, so you want to go really slowly. Okay, so the third case now, we've got patient X and suspected to have giant cell arthritis. Which of the following finding would be observed on a temporal artery biopsy? So this kind of plays well because we just spoke about polymyalgia, and have a go at what you guys think the answer is. So I'll give you guys just a few more seconds to put in your votes. Okay, so well, we've got split answers. Sorry. So we're split between multinucleated giant cells and granulomatous inflammation. The correct answer is number 2, multinucleated giant cells. But the people who answered for granulomatous inflammation are not incorrect as well. Let's just discuss why. So the question here says, they've had GCA, what is a key feature? So multinucleated giant cells are a key feature. It's something, it's an exam favorite question and something that is characteristic of giant cell arthritis. Mononuclear cell infiltration and granulomatous inflammation are not incorrect. They are also seen in giant cell arthritis, but you would not say that these are key features of it. I'm happy that none of you answered number 1 and number 5 because they're the wrong investigation. So number 1 is urine analysis for acute tubular necrosis, and number 5 is when you do lumbar puncture for subarachnoid. So giant cell arthritis is a systemic vasculitis affecting medium and large arteries, especially the temporal arteries. There's a strong link with polymyalgia rheumatica. And in terms of the clinical features, they usually present with a severe headache that's unilateral. They can have scalp tenderness, especially when they're brushing their hair. So that's a good question to keep in your mind. Other features they can have is jaw claudication, vision problems, so if they're double blurred vision, and systemic features like weight loss, muscle aches. The diagnosis is based on their clinical presentation. You can do inflammatory markers, so see if the ESR is raised, and your temporal artery biopsy results. An important thing to note is the complications. So an early and an important complication to be aware of is vision loss with giant cell arthritis and stroke. And then there are a few late complications that they can relapse, they can have the side effects of steroids, strokes, aortitis leading to an aneurysm or dissection. So because one of the complications is so severe vision loss, you want to start them on steroids immediately before even confirming the diagnosis. So if someone comes in, you have a clinical suspicion of giant cell arthritis, you start them on steroid stats before confirming them, and that's to reduce the risk of permanent sight loss. So your initial dose will be about 40 to 60 milligrams of prednisolone, and then you want to refer them further. You want to refer them for rheumatology if it does end up being GCA, vascular surgeons because you want to get a biopsy and confirm your diagnosis, possibly ophthalmology. It depends. If they are presenting with blurred or double vision or any other visual problems, then you will consider ophthalmology as well. Right. So again, what is the risk of patients stopping steroids abruptly? There's no poll, but if you guys open your chats and put in some of your ideas, let me see how it goes. Yeah, okay. So the first answer we got is correct. Yeah, adrenal crisis. And that was just sort of to, just make sure that you guys are thinking about this in the back of your mind. Right. So we'll go through this case and then we'll take a few minutes break just to see if you guys have any questions about the previous cases. So here you've got Robert, who is a 48-year-old male. He presents to his GP with a swollen and painful joint in his right hand. Below you can see an image of it. Given the most likely diagnosis, how would you manage this patient? Right, and the poll should be open for you guys. Right, I'll give you guys about a few more seconds to put in any votes. Okay, so the majority of you have said NSAIDs, which is the correct answer. And we got a vote for allopurinol, which, well, in this instant wouldn't be correct, but it can be. So let's just discuss the answers. So here you got a male swollen and painful joint. I'm hoping that you thought the diagnosis was gout. Yeah, so during an acute flare of gout, you want to give NSAIDs as the first line. If they can't use NSAIDs for any reason, then you can try colchicine or steroids as an alternative. Allopurinol is given for the prophylaxis of gout. So you'd give it once their flare up has calmed down and they don't have any more symptoms of an acute flare up of gout. However, if they are on allopurinol and then they develop an episode of gout, they flare up, you can continue the allopurinol if it's been started. Antibiotics don't really have a role in gout. So gout is a crystal arthropathy. Risk factors include male, obesity, high purine diet such as seafood, meats, alcohol, diuretics, family history, existing cardiovascular and kidney disease. So they've got a lot of risk factors. It'd be useful if you just memorize like 3-4 of them. Common joints. So common joints are the MTP joint, the CMC joint, your disinterphalangeal joint, and the wrist. Clinical presentation, it usually presents as an acute episode of a single joint. It can be hot, swollen, painful, all three, one of them. And it's important that you keep septic arthritis as a differential, and you want to rule that out. Yeah, so if you're thinking about septic arthritis as a differential, you'd want to do an aspiration of the joint, see if there is any bugs growing, any bacteria, any infection, and if there is, you want to treat that. The clinical diagnosis, even for gout, you can consider aspiration, and that can show you things like monosodium urate crystals, needle-shaped. You can consider an X-ray that can show you lytic lesions of the bone or punched out erosions. And in terms of management, you guys did really well. So acute episode, NSAIDs are the first choice, and then you can consider the others. Prophylactic, so lifestyle advice is quite important. If they're obese, you want to advise them on weight loss. You want to give them advice about their diet, alcohol. And again, allopurinol can be initiated once an acute attack has settled. Right. So we're halfway through the cases. If you guys have any questions, I'll give you like a couple of minutes to post them. And if not, we'll get along with the rest of the PowerPoint. So if you just post them either in the chat box or in the Q&A. Right. Okay. Well, you don't seem to be getting any questions, so I'll keep going along. But if you have, just pop them in either of these boxes, and we can deal with them. So let's go on with case 5. Here you've got Ruth, who's a 65-year-old lady who fell off her chair and sustained a fracture of her right hip. Further investigation reveals osteoporosis. The consultant decides to start her on bisphosphonates. Which of the following is a common side effect of this group of drugs? And the poll should be open for you guys. Okay, so I'll give you a couple more seconds if you guys want to put in any more votes. It's fine. Right. So we're split again. So we've got 50% saying it's osteonecrosis of the jaw and 50% saying it's reflux and esophageal erosions. The correct answer is reflux and esophageal erosions. So, right. Yeah. So they've started on bisphosphonates. What's a common side effect? The common one you always have to tell patients about is reflux and esophageal erosions. All the others are side effects of bisphosphonates, so you're not wrong in that part, but they aren't as common as reflux and esophageal erosions. And that is something that you want to warn your patients about. And you want to tell them that when they do take bisphosphonates, they should take them on an empty stomach, sitting upright, at least for 30 minutes before moving or eating to prevent such a side effect. So osteoporosis is basically a reduction in the density of bones. Risk factors include old age, low BMI, female, especially postmenopausal female women. That's because of the estrogen decreasing. Rheumatoid, long-term steroids, alcohol smoking, and decreased mobility. They're usually asymptomatic and they're often diagnosed when either fragility fracture occurs. In terms of investigations, so I've divided them into steps. So the first step is you want to calculate the risk of a fragility fracture over the next 10 years. And you can either use FRAX or Q fracture, and depends on the preference in your area. And then the second step is you want to interpret the above results. So if it's a high or intermediate risk, you want to measure your bone mineral density with a DEXA scan. If it's a low risk, you want to reassure them. In terms, I'm sure you guys have heard of the WHO classification. So you'd measure the T-score at the hip. So if it's more than -1, it's normal. And if it's -1 to -2.5, it's osteopenic. Less than 2.5, you can diagnose osteoporosis. And if they're less than 2.5 plus they've gotten fracture, it's severe osteoporosis. The key number or the fact to remember is less than 2.5. T-score at hip represents osteoporosis. So if it's osteopenia, you want to give them advice about risk factor modifications, follow up and repeat the scan. Usually you want to repeat it within 2 years. And if they are osteoporotic, you want to initiate treatment. So in terms of management, lifestyle advice, exercise, make sure they're getting adequate calcium, vitamin D, stop smoking, reduce alcohol. In terms of supplementation, you can try something like calcium D3, which has both. Bisphosphonates are the first line. So the most common one is alendronate. You can give 70 milligrams once weekly oral. You can alternatively also give 10 milligrams once daily, but I suppose this would be easier for a patient to just take it once a week. Risindronate is also oral. Important to remember that zoledronic acid is only IV. So if for some reason the patient's unwell, they cannot tolerate anything oral, you want to make sure you commence them on zoledronic acid. Side effects, yeah, all the side effects are mentioned in the question. Other things, if bisphosphonates are not working for some reason or they're reacting quite badly, there are a number of things. So denosumab, strontium, raloxifene, hormone replacement therapy, especially in postmenopausal women. These are things just to keep in the back of your mind, but bisphosphonates is the one you should remember. And then you want to follow up. You want to follow them up. Right, let's go on to the sixth case. Here you've got Rachel, who is a 22-year-old female. She presents with a 4-week history of tiredness and myalgia. She is having such episodes on and off for over 2 years. You notice a butterfly-shaped rash on her face. Her blood results show that her full blood count is decreased leukocytes, neutrophils, and platelets. Her CRP is raised. Given the most likely diagnosis, what other investigation would you request? Right, okay, so the majority of you said anti-double-stranded DNA, and then a couple of you said anti-nuclear antibodies. So you are right. Well, I'm hoping that you guys are suspecting SLE, systematic lupus erythematosus, as the diagnosis. Both these antibodies have a role in lupus, but the correct answer here is anti-nuclear antibodies. So Sorry, just give me a minute. Here we go. So yeah, so things that point to lupus is her age, the fact that she's female, symptoms which are pretty vague, or tiredness, myalgia, could be due to a lot of things. But then the butterfly shape rash, kind of characteristic of lupus. Decreased bloods and increased CRP, again, point towards lupus. The first step, if you're suspecting lupus in someone, is you want to check the anti-nuclear antibodies. And then if an anti-double-stranded DNA, yes, it does have a role, but it's more useful in monitoring lupus instead of as a first line for diagnosing it. The other antibodies don't actually have a role in lupus, but it'd be worth if you just read and have an idea of which antibodies are for which conditions. So in terms of systemic lupus, so systemic because it affects multiple organs of your body. Erythematous, well, because of the redness. So basically it's you get a malar rash that's butterfly shaped, and that gets worse on exposure to light. So it's an inflammatory autoimmune connective tissue disease, and it has a relapsing remitting cause. So it gets better, worse, better, and worse. But what happens is because it's an inflammatory and it's an autoimmune connective tissue disease, you've got chronic inflammation that keeps on going on. And because of that and the relapsing remitting feature of this disease, it shortens the life expectancy of a person. So the leading cause of death in SLE is usually either infection or cardiovascular disease. And it's common in women, Asians, and usually presents in young and middle-aged people. Clinical presentation, so you've got non-specific symptoms, and they can be really wide ranging. So for myalgia, fatigue, weight loss, photosensitive malar rash, they can present with mouth ulcers, Raynaud's phenomena, shortness of breath, hair loss. So you can't, when a patient comes in, you're not really sure what's happening, keep SLE in mind because it can be a very valid diagnosis. Investigation, so autoantibodies is your first step. You can also do bloods. Yeah, you want to do their baseline bloods. In particular, you want to measure the inflammatory markers, full blood counts. You can measure C3, C4. And I've said other. Other is a bit vague. It depends because it's a systemic condition. It can affect different organ systems. So let's say, for example, someone's coming with kidney problems, you're suspecting they might have lupus, you can do urine analysis. You can do an albumin creatinine ratio for suspecting lupus nephritis. If you're suspecting another organ system, you might have to alter your investigations according to the symptoms. In terms of autoantibodies, so anti-nuclear antibodies are seen in approximately 85% of SLE patients, which are positive, and anti-dsDNA is useful in monitoring the disease activity and the response to the treatment. But the first step is always ANA. So in terms of diagnosis, you have the SLIC criteria or the ACR criteria. And these basically, you don't need to know these criteria, it's just maybe the fact that there's a SLIC in ACR. So ACR is American College of Rheumatology. And it basically sort of gives you like different features that someone should, SLE will have, and then you basically tick what they do have, what they don't have. In terms of management, there's unfortunately no cure. So the first line, NSAIDs, steroids, prednisolone. If they have mild SLE, you can consider hydroxychloroquine, sun cream because of the malar rash, and then tell them to avoid sun if they can. Other possible treatment options are methotrexate, azathioprine, cyclosporin, tacrolimus, and it can go on. There are quite a few options. The complications are, it's important to be aware of complications of lupus. So cardiovascular disease is one of them. Pericarditis is another one. Pleuritis, infection is a common one. Interstitial lung disease, VTE, and antiphospholipid syndrome. Recurrent miscarriages is also a common complication of lupus. Neuropsychiatric SLE, so they can have psychosis, and lupus nephritis, anemia of chronic disease. So I tried to highlight the ones in red, which are the common ones you see during lupus, but basically what I was trying to represent is that the complications can be very wide-ranging. So you want to try and pick it up as early as possible. Right, let's move on to case 7. Here you've got Ahmed, who's a 29-year-old male. He's presented to the general practice with a 5-month history of lower back pain, which is worse at night. He's also experiencing stiffness that lasts approximately 45 minutes in the morning and improves during the day. Given his history, what condition is he most likely to have? Yep, and the poll should be open for you guys. Right, so you guys are spot on. You all answered ankylosing spondylitis, majority of you, and that is the correct answer here. But yeah, so the things that point to it is the fact that he's quite young, he's 29 years old, he's a male, which makes him more likely to develop ankylosing spondylitis. A 5-month history, he's got lower back pain, which is worse at night. The fact that there is stiffness that lasts approximately 45 minutes in the morning and improves throughout the day, again telling you something inflammatory going on. Yeah, rheumatoid, yeah, again, you guys didn't answer it, but again, you can have it as a differential in your mind. But his features and the fact that he's 29 male more points to ankylosing. Reactive arthritis is no infectious trigger. Polymyalgia, we did speak about it. So you're more thinking bilateral pelvic girdle pain or shoulder pain, which is not the present in his case. And prolapse disc is unlikely to be presenting with stiffness. It could present with pain. And also that if you have a prolapse disc, it's not the symptoms are not likely to improve during the day. So ankylosing spondylitis is an inflammatory condition. There's a strong link with HLA-B27 gene. Common sites are sacroiliac joints and joints of the vertebral column. The clinical presentation is something that it's a gradual onset. It usually it's there for at least more than 3 months. Someone would present with lower back pain and stiffness at least for 30 minutes, plus minus sacroiliac pain and stiffness that's worse with rest and improves with movement. It's worse at night and in the morning and improves throughout the day. And they can have flare-ups. They get better. They think, oh, it's just a back pain, and then it comes back again. So that it's good to take a history over the last couple of months. Typically presents in a young adult male in their late teens or 20s. So males are 3 times more likely to experience this. And a key complication to remember of AS is vertebral fractures. It can affect other organ systems, so pulmonary fibrosis, anemia, aortitis, but you don't need to remember how it can, just the fact that it can possibly affect other systems. Investigation, you can do your inflammatory markers, you can do a genetic test, you might want to do an x-ray of the spine or sacrum, possibly an MRI. And an MRI you would only consider if you still have suspicion and the previous tests mentioned have been negative, but you're still suspecting AS. So this is a classic sign of AS, which is a bamboo spine. And you usually see it in someone with a bit more severe form of AS. And you see that on an x-ray of the spine. In terms of management, you can advise them on physiotherapy, exercise, tell them to avoid smoking. If they're having a flare-up, you can consider steroids. But if it's not a flare, it's just AS as a normal episode, the first point for managing the pain would be NSAIDs. Of course, if people are unresponsive to the above, you can consider other medications such as anti-TNF meds, etanercept, and secukinumab. And lastly, we're coming to our last case. So here you've got John, who is a 45-year-old male. He's presented with a 5-month history of bilateral pain and stiffness in the small joints of his hands. That's the PRP and MCP. And following appropriate investigations and referral, he was started on methotrexate for his condition. Which additional drug was he started on with methotrexate? So have a go at this and see what you guys think. So I'll give you guys about 10, 15 seconds more to answer. This is a bit of a tricky one, so take your time. Okay. So we've got some majority of votes are for folic acid, and then we've got 1 vote for sulfasalazine. So that is right. The correct answer is folic acid. But let's just go through why it's the right answer. So from the history, I'm hoping that you guys came to the diagnosis of rheumatoid arthritis. The 45-year-old male has got a 5-month history, so it's relatively long. Bilateral pain and stiffness in the smaller joints. So as you know, rheumatoid is a symmetrical polyarthritis. And then he was started on methotrexate, which is a treatment for rheumatoid. What else do you start him on? So you start him on folic acid, 5 milligrams once a week, and you make sure that's taken on a separate day than the methotrexate. So, an option number 2, leflunomide, and 5, sulfasalazine, are also treatment options for rheumatoid, and maybe he might need those as add-on. But when someone's on methotrexate, they have to be on folic acid. And that's because methotrexate works by interfering with the metabolism of folate and suppressing certain components of the immune system. So that's why you want to give them folic acid 5 milligrams. Pabrinax is for vitamin B, so it wouldn't be applicable in this case. So rheumatoid arthritis. It's an autoimmune inflammatory symmetrical polyarthritis. Women are 3 times more likely to experience it. Genetics play a role. So HLA-DR4 and HLA-DR1. So DR4 is more common. Clinical features, again, pain, swelling, stiffness, can have systemic features such as weight loss and fatigue. Common joints affected is your MCP, PIPs, wrists, ankles, MTPs, and cervical spine. It's important to note that the DIP joints are almost never affected by rheumatoid arthritis. So if someone's come in and there's something with the DIP joints, either it's a deformity or the X-ray changes, you want to think about Herbert's note in osteoarthritis. In saying that, don't completely rule out rheumatoid. There's always an odd case here and there where it can be rheumatoid. The signs in the hand. So you've got 4 main signs that you should be aware of, and that is the Z-shaped deformity to the thumb, the swan neck deformity, and a boutonniere deformity, ulnar deviation of the fingers at the MCP joints. And here is a picture of a swan neck deformity, which is basically going to highlight a hyperextended PIP and a flexed DIP. And then you've got boutonniere deformity, which is a hyperextended DIP and a flexed PIP. So for me personally, it took a while to get my head around these deformities. So it'd be useful if you just keep the picture and the anatomy next to it and appreciate why such a deformities come about. But the boutonniere usually comes because of a tear in the central slip. So in terms of extra-articular manifestations, rheumatoid can have many extra-articular manifestations. One that you commonly might see is someone comes in with carpal tunnel syndrome, but it's bilateral. So if someone's coming in with bilateral, think rheumatoid in the back of your mind. Other things could be Kaplan syndrome, Felty syndrome, that's rheumatoid, neutropenia, and splenomegaly. They could present with eye problems like scleritis and episcleritis. In terms of investigation, your clinical diagnosis, you want to do antibodies, so rheumatoid factor and anti-CCP antibodies. You want to do inflammatory markers and plus minus imaging. That depends on your clinical judgment. So NICE recommends you refer any adult urgently if they've had persistent synovitis, despite negative investigation results, if it involves the small joints of their hands or feet, or it involves multiple joints, or they've had a history of more than 3 months. And that's because if it's something as severe as rheumatoid arthritis, you want to prevent it to a stage where you can actually visibly see deformities either of the hands or any other parts of the body, and you want to start treatment urgently if possible. So you have a couple of criteria. So again, American College of Rheumatology, I think that's European League Association of Rheumatology. They set out diagnostic criteria, and that's again set out a list of things that you would suspect in someone with rheumatoid. You have a DAS28, which is important to remember because that's useful in monitoring disease activity and treatment response. And then you have HAQ, which is also important to remember because it measures the functional ability. And the full forms of all these terms are measured, have been mentioned in the notes, so don't worry about writing them down. In terms of management, so if it's someone who's you think it's a flare of the pre-existing or new rheumatoid, you can consider steroids and you want to cover them with PPI. But if otherwise you want to consider disease-modifying anti-rheumatic agents, which are DMARDs. So the first line of a DMARD will be a monotherapy. So you consider either methotrexate, leflunomide, sulfasalazine, or hydroxychloroquine if it's mild disease. Usually you see a lot of people are started on methotrexate. So again, methotrexate, 5 milligram folic acid should be prescribed with it. The second line would be that you use 2 of the above in combination. Third line is that you use methotrexate plus a biological agent such as anti-TNF. And the fourth line would be that you use methotrexate plus rituximab. If they are pregnant, sulfasalazine and hydroxychloroquine are the two which you can consider during pregnancy. So they're considered relatively safe. An important thing to note with the drugs in rheumatoid arthritis are the side effects. So I've tried to sort of highlight the key side effects, but it would be worth it if you guys on your own time read about common and other side effects. So with methotrexate, a key side effect to remember is pulmonary fibrosis. With leflunomide, you want to remember hypertension and peripheral neuropathy. With sulfasalazine, you want to note reduced sperm count. If someone's taking hydroxychloroquine, they can have nightmares and reduced visual acuity. If someone is on an anti-TNF medication, such as adalimumab, infliximab, or etanercept, they can have reactivation of TB or Hep B. And if someone is on rituximab, then they can experience night sweats and thrombocytopenia. So these are just things that you should be aware of. Right, so those are all the cases done. And I've got some questions which are just spot diagnosis. So there's a picture and just let me know how you guys get along with that. So which condition is most likely from the x-ray? I'll just open the poll for you guys. So I appreciate we may not have spoken about these conditions, but it'd be a good sort of tester for your previous knowledge. So we're getting the votes in. I'll give you guys a few more minutes to get all the votes in. Okay, right. So we actually got quite a few answers here. And the majority of you have said Paget's disease, which is unfortunately not the correct answer. The correct answer is psoriatic arthritis. A fracture rheumatoid, we got quite a few options. So let's just sort of discuss why this is the answer. So in psoriatic arthritis, and I appreciate we haven't spoken about this, you get a classic pencil in cup appearance. And this is exactly how it would look like. If it's a fracture, I'm not sure where we suspect the fracture, but how I look for fractures is you just go from the outline and you just kind of see if you see any cuts. I appreciate it's not a very clear X-ray image, so maybe that's why you could suspect a fracture, but there's no obvious indication of a fracture. None of you said rheumatoid, so that's good. Osteoarthritis is not going to present, it's more going to present with loss, the classical signs. And Purchase disease of bone is not going to present with a change like this one, like penicillin cup. Right, so second question is, which condition is most likely from the picture below? So I'm gonna give you guys about 5-6 more seconds to answer you. Okay, so I'm going to share the results. So the majority of you have said systemic sclerosis, and then we've got a vote for antiphospholipid syndrome and a vote for Takayasu's arthritis, but no votes for SLE and vasculitis. So unfortunately, the answer here is SLE. And let's just sort of discuss this a bit. So this is supposed to be a malar rash. It's supposed to be, where we go? Yeah, it's supposed to be like a butterfly-shaped malar rash. I appreciate it looks a bit more extreme, especially because of here. But yeah, it's supposed to be a malar rash, and it's a bit of a tricky picture. I know some of you said systemic sclerosis, and I can sort of understand why, but if you see someone with a characteristic butterfly-shaped rash, you would want to know more of the history, but you would go with SLE as your first option. Antiphospholipid syndrome, I'm not quite sure that it does have a rash, so I'm not sure of the reasoning behind that. And Takayasu's arthritis, again, it's uncommon to present in this form. Right, third question, what can be observed in this picture? So I'll give you guys a few seconds to answer that. Okay. Oh, that's perfect. We didn't need to spend much time on this question. You guys answered Raynaud's phenomenon, which is the correct answer. And that's basically, it's a problem that causes decreased blood flow to your fingers, essentially. In terms of causes of Raynaud's, there can be various causes. So like in the previous question, lupus can be a cause, systemic sclerosis can be a cause. Sjogren's syndrome can be a cause, rheumatoid can be a cause. So there can be a lot of causes, but it's just worth knowing how it looks like so you can identify it if someone presents with it. Right. Question number 4. What does number 1 on this picture represent? I'll give you guys about maybe 5 more seconds to finish answering this question. Okay. Yeah. So the majority of you said Herberton's nodes, which is perfect because that's the correct answer. We've got a word for Boutinez and a word for rheumatoid, but let's just discuss them. So as we discuss osteoarthritis, Herberton's nodes HC affects the distal area, distal interphalangeal joint. Rheumatoids is unlikely to affect the DIP, so that's why it won't be the first thing you think about. Bouchard's nose, none of you said because that affects the proximus. That would be number 2. Septic arthritis, it's usually an acute red hot swollen joint, as you can't see here. Boutonniere deformity, well, it would be a bit, if it was something as Boutonniere, it would be a bit more obvious, and you would see the hyperextension and the flexion, which you don't see in this case. You might, here you can clearly see some sort of a nodule or deformity. So something is a sort of a nodule or a node. So the first things you think about is Herpetens nodes or nodules. Okay, and this is the last question. So you guys are almost done. Which condition is most likely from the picture below? Appreciate this is a bit of a tricky one, but I have a guess and see what you guys think. I'll give you guys another few seconds to answer it. Okay, right. So the majority of you said Gout, which is perfect because that is the correct answer. None of you said Pagets, that's good. Rheumatoid, not sure of the reasoning there, but yeah, I mean, you can have it as a diagnosis. Pseudo-gout, again, no. Osteoarthritis is, you can't see the classical loss signs. Yeah. So here you can see punched out erosions, which represent gout. And the takeaway message is that this is not an exhaustive list, so please read around the topic. It's a big topic, so focus on key aspects of common conditions, have knowledge about the side effects of common drugs used. And yes, and thank you very much for attending. I would really appreciate if you guys could fill in this feedback form and just take a minute. And thank you very much.